Welcome to Doctors on Call. I'm Jenna Miller. Among women, breast cancer is the second most common cancer diagnosed after skin cancer and the second leading cause of cancer deaths after lung cancer. On average, 1 in 8 women will develop breast cancer in their lifetimes. About 2/3 of women with breast cancer are 55 or older. Most of the rest are between 35 and 54. Unfortunately, breast cancer is very treatable if spotted early. Localized cancer can usually be treated before it spreads. Cancer of the prostate is the second most common cancerous tumor worldwide and is the 5th leading cause of cancer-related mortality among men. Almost all cases are diagnosed after age 65, and more than 80% of men develop prostate cancer by age 80. There are no warning signs of early prostate cancer. Breast and prostate cancer is our topic tonight on Doctors on Call with our guest, Dr. Perez-Tamayo of Central Care Cancer Clinic.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Russell Regional Hospital, experts, neighbors, friends.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.
Dr. Perez-Tamayo is a radiation oncologist and president of Central Care Cancer Center. Dr. Perez-Tamayo completed her radiation oncology residency at the Medical College of Wisconsin. She was awarded prestigious fellowships to both the American College of Radiology and the American College of Radiation Oncology for contributions and service through education, research, and service activities in the practice of radiation oncology. Her academic appointments include the University of Michigan and the University of Kansas Medical Center. She participated with the American College of Radiology Commission on Small and Rural Practices, was appointed to the President's Cancer Panel, and is a part of the Kansas Comprehensive Cancer Control Panel. Dr. Perez-Tamayo is board certified by the American Board of Radiology and the American Board of Internal Medicine subspecialty of hospice and palliative medicine. She has expertise in brain and body stereotactic procedures along with high dose rate radiotherapy. Dr. Perez-Tamayo sees patients at Central Care's Great Bend, Emporia, and Kansas City locations, as well as Heartland Cancer Center in Garden City, a provider with Central Care Cancer Center. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much for joining us again. We always enjoy having you in the studio. Let's talk about, first of all, are there different types of breast cancer? We know there's different stages. Are there different types?
Well, there are different types, and not just the two main types, which is one is the ductal, which is the most common, which is exactly what it says. It comes from the duct of the breast. If you can imagine the duct that brings the milk to the nipple, that becomes stimulated by something. Could it be estrogens, for instance, in our food, or stress can also stimulate the duct. And it becomes what we call hyperplastic, meaning overdivision, like a hyperchild. Then this hyperplasia becomes atypical, meaning the cells are no longer like the duct cells, and then it fills the duct into carcinoma in situ, meaning in place. It hasn't spread outside the duct, and then it does sometimes go ahead and spread outside the duct to become an invasive cancer. There's the lobular carcinoma, which is the second most common cancer, and that is of the part of the breast that makes the milk. That's at the end of the duct, and this lobule can become just exactly like the duct. It can become hyperplastic, meaning overdivision, atypical, meaning the cells become odds, not like the normal lobule, and then it becomes full of this atypical cells, and then it spills over into the surrounding tissue. Now you can imagine that most of the breast is actually fatty tissue. So when this spills into the fatty tissue in its defense tries to understand what this thing is. It doesn't understand it. It's something that we make. But like for instance, if you were, let's say, breastfeeding a baby, and you had an infection, the infection would be of this fat tissue. You had mastitis. So this mastitis sends these bacteria cells to the lymph nodes through these ducts called lymph ducts to see what kind of bacteria it is, so that the body can fight the bacteria. When it comes to cancer and it sends it to the lymph nodes, it doesn't know what it is, and it sends it to the next lymph nodes, and there's many, many chains. Now, there's also other odd types of cancers of the breast, which are not that common. One of them is lymphoma, metaplastic carcinoma. There's also sarcomas of the breast, but these are seen so rarely. They're really, less than 10% of what we see. So really the main event is most of the 70% are ductal cell carcinomas. And those are the ones that we treat very effectively. There are some that have very high risks, and these high-risk patients, especially if they're more advanced, require more than just standards and easy treatments.
And how do you determine what stage a cancer is at?
Well, we first of all do an exam, and then, of course, the mammogram tells us a lot, whether there's just a local cancer of the size, in other words, T and M. T is the tumor size, N is the lymph node status, and M is the metastatic disease. So we first see how big it is, and we give it a T designation, whether it's 1 to 2, 2 to 4, and so forth. If it is involving the skin, it gets to be what we call an inflammatory carcinoma, which is a T4. And then we have the nodes. It could be just one node, or it could be matted nodes, or it could be nodes beyond the level of what we normally would see with spread, like, for instance, the supra and infraclavicular area, or the internal mammary chain, or underneath the breast called the Rotter system. So that would give you an N designation, and the M is whether it's metastatic to the bone, to the liver, to the brain, or elsewhere, and that would be a stage 4.
And what are some of the symptoms that a person should be aware of?
Unfortunately, in the early stages, there are no symptoms. You need to be aware of your inheritance, number one. If you've had many relatives in your family that are less than 40 years of age that have had cancer of the breast, let's say between 40 and 50, or even younger, then you're at higher risk. You have a high risk feature, and you may have some genetic component to your breast cancer. Usually what number one symptom is that you feel a lump. The lump can be small and feels just like a dry bean, like a stone. It's very hard, but it's mobile. And usually when you feel it is when you're in an odd position. Let's say you're in bed and you're talking on your phone and you happen to brush against your breast and there's something that does not belong. You should not dismiss it. You should pursue it. And then you get what we call a screening mammogram or a diagnostic mammogram. It is very important to know what it is, because there are some women that actually would be eligible for something called Free to Know program here in Kansas. And it is a protocol that you can have things paid for by the state if you are, if your finances are not quite there, and they can do the diagnostic testing and the biopsies, but you cannot have it biopsied. This Free to Know program is before a biopsy is done. Then after that, once we establish that there is an abnormality, the radiologist calls it abnormal either by ultrasound or by mammogram, and then a biopsy is done, usually with a ultrasound guided biopsy. And then after that, the decisions are made. The receptors, which is what the cells have, let's say if you remember Pac-Man, that game where it would, had a mouth. Some cells have receptors, meaning that mouth, and some don't. And so if you have receptors that are either estrogen, progesterone, or other receptors, then you can manipulate this cancer, especially if it's in a higher stage.
Now, you had mentioned food earlier. What causes breast cancer?
Well, there's The cause in very certain is not really known. However, there are family histories of breast cancer that every single woman in the family has breast cancer, and usually it's all young women. Some people, estrogen progesterones are very high in their breast cancer, and eating a lot of estrogen-rich foods like estrogen in milk products that are high in estrogen or beef products that have been injected estrogen can not cause it, but it can make it grow. Or stress. There's many articles causing that actually point to stress as being one of the main risk factors for many diseases, including breast cancer.
Okay, very interesting. We're going to go to the phone lines. We've got Dana on the line from Russell. Hi, Dana. Go ahead with your question for Dr. Perez-Tamayo tonight.
We have a family friend suffering from advanced pancreatic cancer. And after just 2 rounds of chemo, he ended up in the hospital because he was so sick from the treatment. So they stopped treatment for several weeks because he was so weak. But now the doctors are opting for more chemo. My question is, at what point is enough enough? I truly want to know, when does the treatment end up causing more harm than good?
Well, here again, even though this is not breast cancer, pancreatic cancer is a killer almost from its inception. It's very rare to find an early cancer of the pancreas. And if your cancer is a stage 4, if it's an advanced cancer of the pancreas, we're looking at palliation, meaning trying to keep the patient from being obstructed. So if, for instance, this family member has involvement of the transverse colon or the outlet, the gastric outlet, or any kind of area that's going to cause him not able to even handle his saliva, treatment is directed to alleviate these symptoms or prevent them. Now, it is true that if he is a stage 4 and you're not going to get any of these symptoms prevented, and there is no hope for any kind of improvement in survival, then you have to make a decision based on this. Since I'm a palliative and hospice board certified doctor, the definition of someone eligible for this is if your survival is measured in months, less than 6 months. So if your survival is measured in months, and it's okay to keep them comfortable with measures that are pain medication and so forth, then that's fine. The problem starts when you want to give the person IV fluids or, external food just to keep them going, just to have them suffer for a longer period of time.
Very interesting, which brings up a good point of, I'm curious as to how often you have patients come in, they're given a diagnosis, maybe a very grim one. How often you have a patient or their family say, I want to forgo all the treatment, I don't want to, how often do you have that happen?
Well, we actually have the opposite happen, which is very, very sad to me. We have people that have a very good chance, actually, of cure, or at least living more than 5 years, even though they may not be curable, and their spirit has given up. They don't want to pursue treatment, and they still last 5 years, but then they suffer the consequences of the metastasis. They have fractures of bones, they have obstruction, they have loss of weight, their relatives have to take care of them, and yet they don't die. So this is more common. This is much more common than the opposite. The opposite of saying, I really truly have less than 6 months to live, I want to stop. Usually it is this patient that we suggest hospice that don't want to stop. But the ones that we say, look, let's not give up, especially if it's a cancer of the head and neck. Really, the death of a cancer of a head and neck is horrific. Horrific is not even enough. So to try to get in control of that cancer, when you have a good chance, is very important.
What can a patient do for themselves as far as this process?
Well, they need to be their own advocate. I think that number one, examining themselves, and if they feel that something isn't right, something isn't right. And sometimes it's subtle. Like for instance, you're tired out of proportion. You may say, I am working harder, but this is not. There's something wrong. That is a symptom of cancer. Or for instance, you're losing weight. You're eating fine, but you're still losing weight. That's a symptom of cancer. You may have a little lump somewhere, and you get brushed off. No, it's nothing. You need to pursue it. You need to pursue it because you really, it's your body, and you need to be satisfied that everything has been done to identify whatever that is, and clear it from cancer. Like for instance, one of the signs of cancer can be blood clots, and people sometimes don't think about that. Blood clots for no reason is a sign of cancer. So if you have a doctor that is willing to, see under every stone and look at everything to make sure that you don't have a cancer based on your symptoms, you need to have someone that wants to hear you and wants to understand what you're talking about.
Can we talk a little bit about genetic testing, what it involves, how a person goes about doing that, especially if they have a history in their family?
Genetic testing is very simple. It's actually one vial blood, and it's actually quite cheap. Even if your insurance does not want to cover it, there are many places, including, for instance, here in Great Bend, close to Great Bend, that there are grants which cover it, and it's about $200. It's quite cheap. And it tests all possible mutations that are known. You may not be aware that you have a mutation, but you have a history of a lot of cancers in the family. Let's say you have cancer of the colon, where your aunt was in her 40s. You have cancer of the breast, and again, they're in the 30s. You have a glioblastoma, which is a cancer of the brain, in a young sister. And then all of these together give the picture that you are at risk. And the risk may be not of a mutation that is known like that of the breast cancer. There's a BRCA mutation, or Lynch syndrome. But maybe you are especially at risk of antioxidants or hydroxyl groups or anything that has to do with radioactivity.
Okay, what is the survival rate of breast cancer?
When stage 1 cancer of the breast, or stage 0, which is in situ carcinoma, is almost 100%. That's why it's so important to get it early. As we go on to the other stages, or the patients that have high-risk cancers where they are negative in the estrogen and progesterone receptors. Remember, I talked to you about the Pac-Man. They are actually circles and don't have a mouth. And HER2 negative, meaning they don't have the receptor of HER2, HER2. These patients, and especially if they're young, have a more grim prognosis. And their treatments usually require neoadjuvant treatments, meaning treatments before surgery is done. They may require even mastectomies, even though they may want to keep their breasts. And then even that may require radiation. So everything needs to be on the table.
Okay, before we move to prostate cancer, let's talk about how common breast cancer is in men.
Not very common. Probably 1 out of 10 of the breast cancers we see is men. And you would think that men having very little breast tissue, you could pick it up early, but it's on the opposite. Most cancers of the men are far more advanced for reasons that perhaps are due to you don't think about it. Anybody that has mammary tissue can have breast cancer. So men have mammary tissue, and they're usually far more advanced, and therefore their treatments are more complicated and their survival is less.
Okay, what is prostate cancer?
Well, prostate cancer is very common. I did a study when I was at the University of Illinois where I took people that died in the street of just thermal problems, the cold, and we dissected their prostate, and over 50% of men between 60 and 70 had cancer of the prostate. So it is a cancer of the aging cells of the prostate. The prostate in men just the prostate itself just gets bigger. But in the process of getting bigger, the cells become more degenerative. They become perhaps not as exact as their normal cell. And that's why Dr. Gleason, a pathologist in Mayo Clinic, devised a method of determining how aggressive a cancer of the prostate is. He gave a summation, that's why it's a Gleason score, the first number being the majority of the cancer, and the second number giving the minority of the cancer. So the majority of the cancer, let's say, was a 1 to 5. The minority would be a 1 to 5. So a Gleason score of 2 would be 1 and 1, meaning that the cells are so similar to normal prostate cells, they're almost, you can almost determine whether they're normal or they're cancerous. A grade of 5 in the majority or in the minority is so completely abnormal, like sheets and sheets of cells without any kind of definition, that they're a Gleason score of 10, and they are very, very aggressive cancers that go into the bloodstream and go into the bone early on.
So what are some risk factors for prostate?
Well, there's many suppositions, risk factors that have to do with eating and smoking and alcohol. There's some that even say something to do with red meat or carbonized, like the barbecue, and infections and all kinds of inflammatory processes that can occur in the prostate. Do we know for sure? No. The only thing we know for sure is that it does run in families. So if your father and his father had cancer of the prostate, you are at high risk versus someone that didn't.
So what can they do to help themselves?
Well, if it runs in your family, go early, and early meaning 40 or even 35, to your urologist or to your primary care physician and get a PSA, prostatic specific antigen. And it's very inexpensive. In fact, there are fairs that do it for free. You need to have a rectal exam. I get this question all the time. They are not independent of each other. You can have a normal PSA and have abnormal rectal exam, which you feel the prostate. Imagine the prostate being like a walnut. What you're feeling in a rectal exam is the seams of the walnut, the seam in the middle and the edges. So if you feel a lump or you don't feel the seams, that's abnormal. So it is age dependent. A PSA in a man that is 40, that is 4, which is normal for a man that's 60, is not normal. So it is age dependent. So you need to know that if you're a young man and you have a family history of cancer of the prostate, your PSA should be less than 2.
Now, you've been doing this for a while. How has treatment improved over the years?
It has improved greatly in many ways. Not only in the curability, and there's more choices. There's anywhere between standard, treatments where you actually bend the beam, IMRT. I was the first to publish this in the world, which you bend the beam and you concentrate on the prostate and the surrounding tissues. There's also protons, which are available in certain centers. There's also brachytherapy, which are needles that you can put in there. And there's also now something called hypofractionation or stereotactic radiation to the prostate. I myself are on the fence line to some of these treatments, especially the ones that are that shorten the amount of treatment, because radiobiologically, to me, does not make sense. This cancer usually is slow growing, and the opportunity to treat it is when it's at its vulnerable state, which is in the state of mitosis, when it's dividing. So if you shorten the length of treatment, you may miss that window of opportunity to hit the cell when it's vulnerable. Now, there's also other things available. There is hormonal treatment that is in conjunction with the treatment or by itself. There's observation, and then there's chemotherapy for the advanced cases.
Okay, we have just a little bit of time left. How important it is to get good night's sleep, stress-free, eat well, exercise
it's key to survival for every disease. That has been proven in cardiac issues, in cancer issues. Being stress-free in particular is the best. And also eating healthy and organic food that is free of pesticides, free of hormones, free of things that are going to make you sick, not being around like Roundup and things like this. Because your skin, you absorb like if you were eating it.
Okay, wonderful. Thank you so much for being
Thank
our guest
you.
tonight. Again, we enjoy having you year by year. That was our guest, Dr. Perez-Tamayo from Central Care Cancer Center. On our next Doctors on Call, we'll learn about wound care. You can email questions to us for our next program at doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Russell Regional Hospital. Experts, neighbors, friends.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.